this electrolyte imbalance. Just a second. Okay, actually we were discussing about sodium imbalance, and I will just revise again that there is a role of ADH, there is a role of aldosterone. Okay, and actually that day I did not mention this ANP and BNP, atrial natriuretic peptide and barium natriuretic peptide, which are also among the controlling mechanism for sodium. Okay, so ADH, whenever there is any change in osmolality, okay, this is sensed by the hypothalamus, and hypothalamus is producing this antidiuretic hormone, and it is released from posterior pituitary, and it is acting on the collecting duct to monitor the sodium absorption. Okay, so it will be the factor for sodium absorption. Aldosterone is occurring, is acting on the this distal convoluted tubule. It is steroid, and it is increasing sodium, water absorption, and decreasing potassium and hydrogen, removing hydrogen. So this is the basic concept. Again, this is released from the stretch. When there is more increased volume, it will increase the GFR. Like when ANP will be released, BNP will be released, there will be increase in GFR and decrease in sodium and water reabsorption. Okay, so this is the basic mechanism for it. And then now yes.
Sir, can you repeat again the about sir, we understood about the hypothalamus, then what about the GFR? GFR and GFR will decrease.
Yes, you see this one. When this atrial natriuretic and brain natriuretic peptides, okay, they are causing diuresis by increasing GFR and by inhibiting renin and aldosterone release. Okay, got it? Are you clear, Atik bhai?
Yes, sir. Can you explain about the, sir, that is not the topic, but we can do it as the
Your sound is coming very low. If you can speak a little louder. I cannot hear you properly.
Sir, I am telling that if you can explain in this regard, as you are discussing the hyponatremic topic, sir, can you discuss the hyponatremia of the pyloric stenosis as well?
Hyponatremia of pyloric stenosis?
Sir, there is also
I'm really sorry, Adik bhai, if you can be a little loud. Your sound is coming very low.
Sir, he means hyponatremic, hypochloremic acidosis, like that.
Okay. So actually, this is which type of among the hyponatremia which we discussed yesterday. Among the hyponatremia we discussed yesterday, which type of hyponatremia is it? In hypertrophic pyloric stenosis, which type of hyponatremia will be?
Hyponatremia due to decreased intravascular volume.
So there will be decrease sodium. What will be the effect on osmolarity?
osmolarity will be also decreased.
Yes, just a second actually.
Water retention.
Just a second. Okay. So osmolarity will be decreased. Okay. just a second. Osmolarity, because we are, if they are losing both sodium and water, so osmolarity will be normal. See, that's
Yes,
what.
there is no effect on osmolarity. Yes.
Okay, so there's a hypovolemia, and tonicity will be slightly decreased, but what is difference between the concept of this because I was just how to calculate the plasma osmolarity. And how to calculate the tonicity, there is a small difference in it. 2 into sodium plus glucose over 18 plus BUN over 2.8. This is for osmolality. But for tonicity, when we calculate the tonicity, we don't calculate this, because tonicity is because of movement of so urea is freely permeable. Okay, it does not need any it is freely permeable through the different compartments. So this is not counted. Okay, so
mostly the question arises that how much excess body water is present in when you are doing TERP, and how much sodium is required to upgrade that. So there are some formula I will share in your group. It is very
yes,
important for
yes, I will just reach there. So we will just try to understand how sodium disturbances occur in the body. Okay, so I told you that there is role of ADH, there is role of aldosterone, there is role of this ANP and BNP, and it is closely monitored. And how it is monitored? Okay, so actually this one, yes. It is controlled, very critically controlled by this mechanism in the kidneys. Usually it is filtered through the glomerulus, and majority of the portion is reabsorbed in the proximal convoluted tubule. Okay, then from proximal convoluted tubule, there is this descending limb of loop of Henle, and then thin ascending limb and thick ascending limb. So in thick ascending limb, actually all remaining sodium is being absorbed, and rest, when it is reaching the distal convoluted tubule and collecting that, there the effect of ADH comes. So if there is ADH, so it is absorbing the water. So the concentration, you can see the concentration of sodium in the urine will be increased. So ADH is responsible for this concentrated urine. Okay, in which there will be more concentration. You can see here that ADH will act on the distal convoluted tubule and collecting that, retain water and deliver a highly concentrated urine with high sodium of approximately 600 millimole per liter. Okay. Conversely, show that in absence of ADH, the urinary sodium may be as low as 80 to 100 millimole per liter. So this is to understand how sodium is being regulated. Okay. So I will come back to your question, Atik bhai. We will just discuss about it. So, okay. So you see, this is what I was telling you, that whenever there is a little increase in osmolarity, ADH is released, and there is thirst mechanism to increase the water intake. So to maintain the water balance. Okay. ADH is also secreted in response to decrease in arterial pressure and intravascular volume that are detected by low pressure baroreceptors in the right atrium and great veins. Okay, and high pressure baroreceptors in carotid sinus. Hypovolemia and hypotension also result in increased sympathetic activity and activation of renin-angiotensin-aldosterone system. You understand this point, because this is very important to understand how this is occurring. Okay, So whenever there is hypotension, hypovolemia, and it will be directed by the low pressure and high pressure receptor, like baroreceptors in great veins and atrium. Okay, and this carotid sinus. Okay, and then this will be the mechanism to control the not only the sodium volume and osmolality, even this will be controlled. Okay. Disturbance of sodium balance is a common thing, which is very common in whenever there will be brain injury, this mechanism will be lost. Okay, so that's what we discussed yesterday. We will just try to repeat it and just focus on here. Okay, so it is less than 135. Okay, I will explain to you something rather. It's very difficult to explain, but I will just try to give you an insight. If you make a component like this is ECF and this is ICF. Okay, so whatever fluid we are injecting is coming in here, and there is also this interstitial space, but this is like permeable, so this is communicable. So if we are giving, for example, dextrose water, 5% dextrose water, what happens?
So the osmolarity will be reduced.
No, what will be happening here? Because here, like you can say that one thing is if you say that here in this direction you take the osmolarity, okay, and in this direction you take the volume. So what will
So
be effect?
volume will increase.
Sorry, volume where will be increased?
Volume will increase
Where?
in extracellular fluid.
No, because this is hypotonic. So water will move inside.
Yes, that's why it causes RBC swelling when we give 5%
Initially,
extra.
extracellular fluid volume will increase, but within a very short time, the shift will be towards intracellular fluid.
Yes, yes, okay. So that's why we usually don't prefer hypotonic fluids. Okay, so that is the reason, because what will happen, that more water will go inside, so this volume will increase. I wish I have better drawing. The volume will increase and osmolality will decrease. Okay, you understand? I will just try to, I don't know, I'm not, actually this is something new for me, but I'm not very good in this graphics, but I hope you understand. So what will happen, that osmolality, I told you that this in y-axis, this is osmolality, and x-axis there is volume. Okay, so if you give 5% dextrose water, because it is hypotonic, so what will happen, that water will move inside. So volume will slightly increase and osmolality will decrease. Okay. Conversely, now, just a second. Now, if you, in the same chamber, if you add normal saline, what will happen?
Sir, it's isotonic. I think nothing will happen.
So there will be no change between the compartments. Okay. And if, for example, if you give hypertonic saline, so water will move from the cell outside.
ECF to ECF,
Okay.
ICF to ECF.
Yes. So the volume will decrease. Volume will decrease and osmolality will increase to balance it here. Okay. So this is the just to understand what happens, because similarly will be if whenever we are actually treating, that's why if someone asks you how to expand among the crystalloids quickly, that's why this is the only use of normal saline. That's why we said that whenever there is in such condition, we have to give normal saline when we want to increase the vascular compartment. Okay, so this is to just explain to you this thing. Okay,
Will it be volume contraction then?
Volume contraction? No.
Okay.
Volume contraction, how volume contraction? With hypertonic saline?
With hypertonic.
No, there will be not effect on volume.
Okay.
Intracellular volume, fluid volume will be decreased. ECF will be not same.
Slightly it will increase because if intracellular volume will be less, then
So
that
sorry,
volume
the
obviously will
intra,
go to the
like it will
extracellular.
not shrink. Actually, his question was that volume will be shrink, so it will not be shrink. It will slightly increase or it will remain normal, towards normal. If you are
Got it.
giving, I'm sorry.
The volume contraction of the brain will occur.
No, the intracellular volume will be decreased. Okay.
No, I think he's telling about the volume contraction. That is, we use it in a head injury to
Yes.
decrease the ECF. That will contract the neurons.
That is the role of giving mannitol even. Okay, because when we give mannitol, ICF, we give here mannitol. So
Yes.
it is
Volume contraction of the brain will occur. Volume
yes,
contraction of the
water
brain.
will go from ICF to ECF. So the brain swelling will decrease. Okay, Dr. Nadeem, you understand?
Yeah, thanks.
So, okay. So these are the basic features of hyponatremia and hypernatremia. Usually neurological features started from lethargy. Both hyponatremia and hypernatremia will almost have similar. Here will be more irritability. There will be hyporeflexia. Here will be hyperreflexia. But you can say that it's sometimes it is difficult to differentiate in clinical features between hypernatremia and hyponatremia. They can almost mimic each other. Okay. So the Atik bhai, the thing which you were telling, we will just come to here. That is the iatrogenic increase like of free water as happens or hypotonic fluids suddenly are absorbed in the this dextrose water, which I give example. It's also true for TURP syndrome. Okay, Atik bhai.
Okay.
Okay, so causes. So iatrogenic hyponatremia is not uncommon and usually result from administration of inappropriate hypotonic fluids, often in the post-operative period when ADH levels are raised. Why it is so? Can anyone answer? Why ADH levels are high post-operatively? This is because of stress
response.
Okay. However, after brain injury, hyponatremia occurs most frequently because of the syndrome of inappropriate AGH or the cerebral salt wasting syndrome. Actually, they are in opposite direction. We will just shortly discuss about both of them. So underlying cause of hyponatremia should be identified and treated in context of brain injury and expectant and super supportive treatment strategy. Because what will be the problem if we don't treat this hyponatremia? What will happen? Hypernatremia or hypernatremia, if we don't treat, what will be the effect?
Coning of brain.
No, Dr. Humera, your answer is not not wrong but not correct.
Sir, different manifestations can occur in the presence of hyponatremia, like seizures can occur, conscious level can decrease, and the nerve impulses.
Actually, bottom is these are all part of the
Brain edema.
No. You are all of you are telling the right thing, but the basic concept is you are trying to avoid secondary brain injury. Okay, so all these factors which we are saying will increase the secondary brain injury. So whatever, because these things which are occurring as a result of primary brain injury can further deteriorate the condition. Okay, so coning can occur because of raised ICP and other things which you are saying fits this seizure activity can occur. Okay, so I hope you understand. Okay. Okay, so that was I was because I had read from this article before. I couldn't open this article yesterday, so it was actually I found it to be better source than the one which we discussed yesterday. So actually, the basic theme is that usually 0.5 millimole per liter per hour or 8 to 10 millimole per day. You have to correct in either side like that. Okay, so if you suddenly correct it, so the water will come out and it can cause central pontine myelinosis. Okay, so what happens in it syndrome of inappropriate ADH can be because of traumatic brain injury, brain tumors, and some drug related hyponatremia, especially anticonvulsants and antipsychotics. It's not written here, but antipsychotics, they can also cause hyponatremia. Okay. Okay, pathophysiology is fully not understood what is happening, that ADH release is related to, yes, one more thing I just wanted to revise the basic concept, how ADH is controlled. How ADH secretion, I told you that it is from hypothalamus. So
Yes,
what,
supraortic
yes,
nucleus.
so what is the negative feedback for it?
ADH, I guess.
Okay, one more thing. What about aldosterone?
Collecting tubule, say, sir,
Yes.
that there is collecting tubule,
No,
aldosterone.
Atik bhai, my question is that what stops ADH? Like, what is the negative feedback for aldosterone?
Increase in sodium.
Sir,
Uh,
osmolarity, because osmoreceptors are there in the hypothalamus.
Nadeem bhai, it will not be increase in sodium, it will be decrease in sodium. Okay, it will be decrease in sodium. So ADH will be stopped. So if this stop mechanism does not occur, this negative feedback, ADH will keep on increasing and increasing and increasing. Okay. So normally the osmoreceptors in hypothalamus will respond to the sodium level. Okay. And what about aldosterone? How aldosterone levels are controlled?
Sir, JG apparatus,
And the JG apparatus, and actually it responds to
macular
potassium.
densinate.
Potassium. Very low potassium will decrease aldosterone. Okay. Okay. So there is loss of control of ADH release, as I told you, and plasma ADH concentration is unaffected by continued fluid administration intake or by osmotic stimulus. ADH concentration is therefore inappropriately high in the context of production of small volumes of concentrated urine. Whenever ADH is increasing, actually the concentrated urine is coming, but here everything is autonomous. So what is it, the result? Hypotonic hyponatremia, sodium levels less than 135, on osmolality less than 280. Urine osmolality, yes, this is the important thing, that urine osmolality is more than serum osmolality. Okay. And urinary sodium concentration more than 18 millimole. Normal thyroid, adrenal and renal function, because they are also the cause of hyponatremia. Clinical euvolemia, absence of peripheral edema or dehydration. Absence of dehydration in SIADH is very important, as this is key feature differentiating it from cerebral salt wasting syndrome. Because in cerebral salt wasting syndrome, there will be hypovolemia. In SIADH, there will be no dehydration.
No signs of dehydration.
No
CVC
signs of
will
dehydration.
be less.
Okay, because in cerebral salt wasting syndrome, there is hyponatremia. Okay, and there is hypovolemia. Okay, so you can see in cerebral salt wasting syndrome, there is hypovolemic hyponatremia. Okay, and in SIADH, there is normovolemic hyponatremia. This is the difference. And similar, the same place, Usman, if you can, because I was not able to explain in a very nice way this pseudo hyponatremia. I was just reading it. It was saying that it is actually I just have you got any concept of pseudo hyponatremia?
Sir, I had,
Okay,
but
we'll leave it
unfortunately I
for
forget.
a while. I had just
Pseudo hyponatremia when you calculate in lab.
yes, yes. Actually, that is what I found, and I just was searching it. Just a second, and I found it. The reason here. This is because
Due to some error.
not error actually. If there are some specific conditions like if there is hyperlipidemia, this you see hypercholesteremia, hyperproteinemia, hypergammaglobulinemia, it will result in inadvertent
Falsely low. It is
false
not low, but in the lab it will come as
low.
falsely low.
Low. Yes. Okay. So that is it. Okay. So SIADH is often a self-limiting disease. Okay. After brain injury, and treatment should only be if the patient is symptomatic. The serum sodium is significantly low or falling rapidly. Electrolyte free water restriction. Okay. Initially to 800 to 1 liter per day forms the mainstay of treatment of SIADH, and usually result in a slow rise in serum sodium 1.5 millimole per liter per day. However, such a degree of fluid restriction can be difficult to achieve because it may be unpleasant for conscious patients. Worsen cardiovascular stability, because if patient is cardiovascular stable, how will you do it? So in that case, you will use hypertonic saline. Okay. Just to again revise about it, that there are 2 to 3 ways to treat hyponatremia. One is this fluid restriction. Okay. Other is hypertonic saline. Okay. Normal saline, and in certain condition, diuretics. Can diuretics control hyponatremia or no?
So diuretics can cause hyponatremia.
No. Can diuretics will be used in hypervolemic hyponatremia?
Yes.
Diuretics will be used in cases of hair where there is congestive heart failure, nephrotic syndrome, liver failure. Okay. In that condition, you have to give some diuretics. So, okay. Hypertonic saline infusion should be discontinued when serum sodium reaches 120 to 125. And different classes of drugs are effective though through different mechanism. Increased in excretion of water with furosemide or other diuretics. Simultaneous saline or salt supplementation should be administered to replace the associated sodium loss. Okay. Like water, you are giving furosemide and you are replacing with isotonic fluids. This is also one of the way. Inhibition of renal responses of ADH by demeclocycline or lithium. Lithium is also causing actually lithium is also causing this
Lithium mimics
ADH.
sodium basically.
Huh?
Lithium mimics the role of sodium.
Yes. Okay. So demeclocycline is the least toxic, and an initial daily dose of 900 to 1200 milligram should be reduced to they are just told the reading. ADH receptor antagonists, such as, I have no idea about these medication, but they are different mechanism. They are just trying to, but the basic theme is that usually it is self-limiting. If you are treating the brain injury, it will be just part of it, and you have to avoid the secondary brain injury by controlling the bad effects which are being caused. Okay. So actually it will be self-limiting as soon as the brain injury is getting better, and you are avoiding any factors which are causing further deterioration. This will be treated. Okay. So salt wasting, cerebral salt wasting syndrome. It is characterized by renal loss of sodium, resulting in polyuria, natriuresis, hyponatremia, and hypovolemia. Okay, this is also after head injury. Its exact mechanism is not known, but it can occur after head injury. It is predominantly associated with subarachnoid hemorrhage and traumatic brain injury, but has also been described after brain tumor, ischemic stroke, or TB meningitis. It usually occurs in first week after brain injury and resolves spontaneously within 2 to 4 weeks. The exact incidence is uncertain. Okay, because many cases have been and continue to be mistakenly diagnosed as SIADH. So for that you have to assess the volume status. The differentiation between cerebral salt wasting and SIADH will be through dehydration. So that is why the status of fluid balance will be very important. All the parameters which we use for assessing the volume status. Okay, so the precise pathophysiology is unclear, but raised level of ANP or BNP are likely to mediate, at least in part, because they are causing natriuresis and hyponatremia. As I told you, that ANP and BNP have a critical role in our body. Okay, the BNP is also a marker to see the progress or prognosis in heart failure. Am I right, Usman?
Yes, sir. BNP levels are nowadays measured.
Yes. Okay. So biochemical criteria: low or normal serum sodium. I tell you something. There is no MCQ exam. Atik bhai, can you recall any question related to other than calculation? Forget about calculation. Any question which can recall between cerebral salt wasting, SIADH, diabetes insipidus, because I think there is no exam of anesthesia which will be finished without this question, this topic. Okay, so and it is sometimes very difficult to understand if you don't understand the basic theory. There it is related to ADH, and ADH is absorbing free water, so that is resulting in hyponatremia. Here there is something which is losing the volume, so water and sodium is losing. Okay, so low or normal serum sodium, high or normal serum osmolality, high or normal urine osmolality. Okay, increase hematocrit because there is loss.
Sir, excuse me, sir. Can I
Yes,
add something?
yes, yes.
You are doing excellent job. But sir, in MCQs, the big concept, yeah, it is mota concept. We told that if there is hypernatremia, then
Okay.
mostly it is diabetes insipidus. If there is hyponatremia, then mostly we have to differentiate between SIDH and cerebral salt wasting syndrome. If the patient is euvolemic, then and the sodium level is around 125 or 122, 123, then it is SIDH.
Yes.
And if the sodium is below 120 and the patient is dehydrated, then most straight away it is cerebral salt wasting syndrome. And so the treatment is when it is above 120 above, then you have to restrict the fluid. And if it is more than 125, then we can give demeclocycline for SIDH. And for cerebral salt wasting syndrome, we give slowly sodium. We give slowly sodium.
Isotonic. Isotonic saline. We will give isotonic saline. Okay.
Yes.
So because we have to just treat it as a dehydration. Mainly
So
there is
normal
dehydration.
saline.
Normal saline.
पंखा चल रहा है ये वाला?
You know, Dr. Humera, never mute your mobile. Dr. Humera, this is not fair. I always pointed you out. Anyways, so this is just differentiating point. You can see that there is in both sodium levels are less, but osmolality here is decreased. It may be normal or it may be increased in cerebral salt wasting. And urinary sodium usually are high in both of them. Okay, and other features are almost the same. Hematocrit will be decreased here and increased here. Okay. So this is how, okay.
Question here, when we talk about urinary sodium, so is it for 24 hours or a one-off at random?
It will be random. 24-hour is usually for, actually, I'm not sure. Just a second, let me think. Atik bhai, it will be 24 hours or it will be spot? I think it will be spot. It should be spot.
Okay, okay.
Yes, Usman. What is your opinion? Where is Usman? He has
Are you
gone.
talking about water deprivation test?
No. He's asking that this urinary osmolarity we are seeing in 24 hours or in single urine test.
No, sorry, in 24 hours collection, sir.
In
Confirm.
24 hours collection. Of course, it will be, but some, because this is a volatile condition. This is not a fixed condition. So that is why 24-hour makes sense. But some information you can get it in serial readings. Okay. So both make sense. Okay. So in hypernatremia, as I told you that there are so many causes. We will just discuss in detail hypernatremia, but one of them after this traumatic brain injury is diabetes insipidus, and usually it is neurogenic because there is another form of diabetes insipidus which is just a second. Okay, which is nephrogenic, in which tubules are not responding to ADH. Okay. So here, usually hypernatremia is also being read in the same way that volume may be normal, volume may be high, or volume may be low. Okay. So here in diabetes insipidus, volume will be, yes, in diabetes insipidus hypernatremia, it will be low or high or what?
Increased volume.
No. Should be decreased volume, no? Because there is no
In
ADH.
diabetes insipidus,
Yes.
the urine volume.
Urine volume will be increased.
Yes.
I'm talking about body volume, hypovolemia. There will be
Sorry.
hypovolemia. Okay.
Yeah.
So it is urine osmolarity is high, serum sodium is high serum osmolarity. Okay, and abnormally low urine osmolarity. Okay, because all the water is being wasted. So for this one, replacement and retention of water and placement of ADH, in unconscious patient, fluid replacement is achieved with water administered via an nasogastric tube or IV 5% dextrose. Okay. Excess fluid input is a risk in unconscious patients, and treatment should be guided by accurate assessment of volume status. If urine output continues more than 250 ml per hour, synthetic ADH, this vasopressin is being given, okay, intranasally or IV. And again, the same rule, it should not be corrected, not more than 10 millimole per day, okay. So, and you will also avoid high sodium containing fluids. Yes, Atik bhai, now you tell me that how to replace sodium.
Sir, we will take the body weight 0.6 into body weight into initial sodium and minus final sodium.
Okay,
Then
and how will we give? How will we like?
if if it is more than, then we will give in milliequivalent. Sir, there is a formula of what I can share it if you like.
Just a second. This is for estimation, water deficit. Just a second. Like for example, my question is that if you calculate that how many millimoles total you have to give, then how will you divide it? How will you calculate that which fluid you should give and how many mils? This is my question.
Sir, in normal saline, we can calculate easily by it's written on the it's written on the normal saline. I think 155 sodium in each ml, or
Yes.
we calculate by this by giving mLs per hour.
Yes. Yes, you see the this is how we will be. So if we calculate that total body water is 30 liter and serum sodium will increase approximately 1.4 milliequivalent for a total sodium of 1. So in 3%, if you are giving 3%, it will have around 500. Am I right? 500 milliequivalent per liter.
Yes, yes.
Actually, this topic is very important and it is actually very complicated. So yes, you are right that in MCQ they are asking this question, but this hypernatremia will not leave you ever, I guarantee you. Okay, so I hope you have Dr. Mozama, are you clear a little bit more than yesterday? Yes, Mozama. Okay, we will inshallah continue tomorrow. Okay, so I think it is enough for today. Any
Yes, sir. I have sent some question related topic MCQs in the group. We depend upon it.
Okay, okay. Actually, I just I don't want to rush in this topic. Maybe I will take some time. We will discuss this inshallah tomorrow. This is actually related to ICU, but it will remember one thing. If you understand this topic, you will have a command on number of related topics. It's not only sodium. It's like a jigsaw puzzle. If you understand this sodium, potassium, magnesium, calcium, phosphate, and this acid-base balance, you will understand a lot of ICU. Even practically, clinically, it's one of the most important thing. Okay, so because maybe in exam, and I tell you that no exam will be finished without questions related to fluid electrolyte imbalance. Okay, so thank you very much. Inshallah, we will continue tomorrow. Bye bye.
Okay, sir. Thank you, sir.